Okay, so I'm going to make a start. So welcome everybody to this third webinar in our NIHR ARC National Palliative and End of Life Care Network webinar series. Could you move us on to the next slide, please, Nick? So just to remind everybody what the collaboration is all about, as you know, NIHR funded 15 ARCs from October 2019 running up until March 26 to do applied health and social care research and undertaking research where it's needed. This cross-ARC collaboration on palliative and end-of-life care is co-led by Professor Irene Higginson from South London and myself from the East of England, ably supported by Mev Hokaglu to help us get the webinars up and running. And the idea of the ARCs and this particular network is to drive collaboration, maximise impact, and to deliver national impact and provide expert advice where it's needed. So this third webinar is focused on assisted dying and is going to focus particularly on what we can learn from the international research on assisted dying. And we are doing this topic because it was strongly requested by stakeholders who were interested in the topics we were covering. And so I'm really pleased to welcome Professor Nancy Preston and Professor Suzanne Ost. So for those of you who don't know her, Nancy is Professor at the International Observatory for End-of-Life Care in the Faculty of Health and Medicine at Lancaster. She's a world-leading researcher on the impact of assisted dying on families and healthcare workers through her international research. And she's recently given evidence to both the Health and Social Care Committees on assisted dying for the British and Irish governments, and she's also an advisor for the Nuffield Council. And then Suzanne is based in the law school at Lancaster and was an expert advisor to the Jersey Citizens Jury on assisted dying and again the Nuffield Council's Citizens Jury. And she's written extensively on assisted dying, including a demedicalised model, and conducts research in the field. So Nancy and Suzanne are going to present their international research on assisted dying and practical issues about the current bill that's before UK Parliament. And they're going to give their presentations, and we're going to ask you to put any questions you have in the Q&A function on the webinar. So please avoid using the chat, but to put the questions into the Q&A. And if you could save any sort of general thoughts from the chat so that we can bring them into discussions after Suzanne and Nancy have presented. So I'm going to hand over to Nancy.
You can see them all right, is that okay? Yeah, brilliant. So yeah, thank you so much for inviting Suzanne and I to present today. As Morag says, we're going to be talking about what we can learn from the international research on assisted dying. This isn't to say whether we should or shouldn't legislate on assisted dying, but rather to present the evidence as we've understood it across different jurisdictions where it is already legal. Ultimately, it will be politicians who decide on what happens about assisted dying, particularly in the UK. So the first thing I wanted to do was thank the PhD students upon whom this research is based. So we have Deborah Lewis, who was the first student we had about 10 years ago and did interviews with healthcare staff in the Netherlands about predominantly euthanasia. And I remember saying to Debbie, you'll never get any participants, and people were knocking on her door. Then we have Claudia Gamonde, who did interviews with both healthcare staff and bereaved relatives in Switzerland, where it's predominantly assisted suicide, that is the term they use. Jane Lowers, who did interviews with bereaved relatives in the US about voluntary stopping eating and drinking. Sherry Miller, who did interviews with healthcare staff in Washington State, where medical aid in dying is legal. And Jan Fish, who did interviews with bereaved UK relatives after an assisted suicide abroad. So the plan for the talk is to give you a little bit of a background about where we're at with assisted dying internationally. And then I'm going to talk a little bit about the research we've done with healthcare professionals and the impact on them, and then the impact on families. And then Suzanne will develop what I've said by looking at alternative models of assisted dying and particularly commenting on the bill before Parliament. So I think the first thing to say is terminology is incredibly complicated in this landscape, and overall we tend to use the word assisted dying But in Europe, the two key terms are probably euthanasia and assisted suicide. So euthanasia, where the doctor or the nurse actively would inject someone with a lethal drug that would be intentionally ending their life. Whereas assisted suicide, the doctor would be helping them by maybe assessing and prescribing that the person could have drugs to then intentionally and voluntarily administer to themselves. And the most common form of that would be an oral medicine. But increasingly in places like Switzerland, that is an IV, and the patient may open the IV to allow the drugs to go into them. In the North America and in sort of Australia, they're much less likely to use the term suicide, and it's actually really seen as a bad term to use. And they will talk about medical aid in dying, voluntary assisted dying, so that even the terminology is loaded in assisted dying. If we think about this increasing legislation, I can remember when we started first doing these slides, and thanks to Sherry for this slide, and we were talking about the different types, and it's just got so complicated. And these were some of the first countries who've had it around for a long time, with it starting, really it starts in Oregon, but it then moves on to the Benelux countries. But in Switzerland, they're in an odd situation where they had an act that you could assist someone to die, and in a sense doctors are acting there outside of the law in a way, as a friend or as a volunteer. They have no really strong guidance on what they can do. So it's permitted, it's just not illegal to do it, rather than the others have more of a legal statement to say that the law has changed and this can happen. But as you know, more and more places this is becoming introduced. Some of the later ones being, you know, Portugal, Spain, Ireland, being discussed in places like Italy. So things are really moving quite quickly. Most commonly, it has been euthanasia that is starting to be put in place. But some countries, such as Germany, are kind of allowing a more Swiss system, where perhaps Dignitas is setting up there. And also in Austria, they have a system largely outside of the healthcare system. But Suzanne will talk about those more later. This is an old study we did where we were trying to look at the rates of assisted suicide and euthanasia. And at this point, so we've only had data on this up until 2017, it felt like an assisted suicide, an oral ingestion of a drug, felt more protective than euthanasia. Those rates seem to go higher. And I think most people are aware in Canada, the rates have gone a lot higher, which is predominantly euthanasia. Where both are allowed, you tend to find it's probably 90–95% or higher euthanasia rather than assisted suicide. Why people choose euthanasia is difficult to tell, but there was an interesting study in Belgium where they asked people who had a mental health condition, because it can be legal for unbearable suffering for people with a mental health condition. And the two reasons I remember coming out of it by one participant was, one, that it would work, so they'd had multiple suicide attempts and they'd had failures, but two, it was more acceptable to the family and society to have a doctor do this to you. So maybe that's why people prefer euthanasia over assisted suicide, where you're involved perhaps in swallowing a drug, because again, there's the risk it may not work or could take a long time. So moving on to our research with healthcare professionals. So in the Netherlands, we interviewed clinicians, doctors, and as one doctor said, I can discuss with the patient, with the team, and agree it's the best option. But to take away the life in a moment and inject the medication, that's something else. I'm still not ready for that. And this is an overriding theme that comes out from interviews, is that even if you are in favour, and quite a lot of people are in favour of a change in the law, they don't actively want to be involved themselves. And it's also quite draining on you. People talked about an attrition on them of being involved in actively performing euthanasia. I had a colleague who was all for it, and she said she's now, I can't do it anymore, because even if you're in favour of it, it becomes a burden when you do it 3 or 4 times. It's stressful to kill somebody. We do know the MAID teams in Canada and in other jurisdictions, particularly Right to Die Association volunteer doctors, will do multiple cases. These interviews were more with people where it's part of your main care team. The other thing that came up, this was never a normal death. Now, these interviews were in hospices, they were in care homes where death was very normal, but they said it was sort of a place you'd remember the room, you'd remember the person, a death that stays with you. So it's always a little bit strange that someone is going to die tomorrow at 7 o'clock. It's very strange. So it's something that's not really been normalised. And this is in the Netherlands, where this has been around for a few decades now. But there was also a need for support and reflection. So if you were going to do this, this is what one of the doctors said, it's important to arrange support for yourself. On the day you perform the euthanasia, it's very important to have somebody to go out with in the evening. It's not normal and it has a lot of impact. Sometimes you read about physicians who perform 6 euthanasia cases within half a year. I can absolutely not imagine that. For me, it takes a year before I get over it and I think, okay, I'm ready for a new trajectory. So whatever happens in any country, there needs to be good support for the clinicians involved. There was also a feeling that within the Netherlands, it was very much part of care. They felt that requests were made to all healthcare professionals, although the focus often in the media is around doctors. Most of the requests would initially go to nurses. But there was some issues about feeling about being a conscientious objector. So I can totally understand this patient wants euthanasia, but it doesn't mean I want to do it. And there was concerns about how that made that relationship with the patient. In a lot of cases, optimising palliative care resolved most requests. And for some people who are very in favour of it, they felt it was a continuum of care. So euthanasia is something that is part of a treatment trajectory you go through together as a patient and the physician. It feels wrong if patients should go to a clinic getting their euthanasia as a sort of product. It shouldn't be like that. Interestingly, when we interviewed patients, they never had any concern about going outside of their usual healthcare team. They were just glad they got it. In Washington State, where it was legal, this was a medical social worker, and they said, I find the intersection between death with dignity and hospice really interesting. But the reality is most people that are doing death with dignity are on hospice. It's uncharted territory for the culture. So there's this uneasiness, felt more so, I would say, in Washington State than came across in the Netherlands about the relationship perhaps between palliative care and death with dignity in this case. Some of the hospices were religious and they were told that the staff couldn't talk to patients about death with dignity. And this could cause quite a lot of problems. So they said, I'm not allowed to talk about death with dignity. I don't know the process. So how can I educate patients who ask about it? But what we do know, Josep Portasalas did research in Spain, and if you talk to patients about a desire to hasten death, they're far less likely to have the hastened death. And so this could almost be counterproductive, banning your staff from talking to patients. And some of the medical social workers in particular we interviewed, they had actually come in and found patients who had shot themselves. And I'll come on to that a bit more. The other issue in the US we came across was the cost of medications was so high. It's a barrier for so many people. And the cost of medications had gone up, which they think was in reaction to the pharmaceutical companies not wanting to be associated with the death with dignity. There was also issues about pharmacists, finding a pharmacist willing to dispense the drugs. So here's an example if there's no discussion. He had a fear of getting into pain, so I'm not sure he trusted us in hospice that we could mitigate pain if he got into it. He shot himself in the head. He left a suicide note and apologised to his family for leaving a mess. Never saw it coming. There was no depression notable leading up to his suicide. And these are sometimes people who already have all the right paperwork to have death with dignity, but they just can't afford it or access it. Sherry, within her research, started looking at this sort of what's the difference between a suicide and a natural death. And what was interesting, voluntary stopping eating and drinking, where people make a really conscious decision to stop eating and drinking, can take sort of 10 days or longer to do this. That felt much more natural than, say, medical aid in dying. Other people did intentional overdose. They saved up their drugs again, if they couldn't afford the medical aid in dying. And of course, because of the US, there were the gunshots. In Switzerland, palliative care doctors, most are not involved. It's rarely permitted in hospitals because the hospitals don't want to be associated with it. And often that's a decision made at a canton or a regional level. Some of the hospitals do allow their staff to assess, prescribe, and allow it to happen on their premises. They're very few. Others will say the Right to Die Association doctors need to come into the hospital and perform the act. Their own hospital team cannot do it. The doctors felt like they were acting in a legal vacuum, which might sound negative, but they actually felt it was easier then for them to not be involved. So they could talk to people about it, but they didn't actually have to actively get involved. They recognised that often their values didn't correspond to the patient's expectations, and they did respect their wishes even if they didn't agree. But some talked about having multiple conversations with patients to almost time out, so that it made it difficult for them to actually access the service. And they were a bit reluctant to suggest they could go to the Right to Die Association, which is ultimately where most patients ended up. And most of the deaths occurred with Right to Die Association volunteer doctors in the patient's own home. They just were lacking a system often to navigate to them. But I thought this is part of the EAPC guidance, where it says it is the responsibility of palliative care professionals to hear and explore the implicit or explicit requests for euthanasia and address the suffering underlying these requests. So there's a bit of a continuum of involvement of healthcare workers. So we often think it's an either or, but it's probably more a continuum. So some would say, I can't be involved. Others might be willing to have a conversation. Others might be willing to assess, but they wouldn't prescribe. Others might prescribe. Others might actually perform euthanasia. Some might limit how many they do. Others say it's okay and I can do multiple. There's still a really big secrecy around this. There's talk in Australia that it's still a taboo. And so how do you find doctors willing to do it? And there's also a fear about how you'll be viewed by others, particularly in palliative care, if you are known to get involved. So the research with the bereaved family members in Switzerland, what we heard from the families is there were these sort of 5 phases that patients went through. So the first was contemplation. And this is kind of where the patient ruminates alone. Sometimes they kind of always knew that they were going to go for an assisted death. They often described the person as someone who wanted to be in control, and they wanted to have control at the end of their life. They then are looking to gain acceptance, usually with a key family member or a family friend, and they're looking for someone to work with them and assist them along the assisted dying journey. They don't want to tell lots of people, and I think we can all imagine that someone with any sort of advanced condition, having these conversations is quite difficult. If they tell lots of people, they're going to have multiple opinions on them. So I think it's understandable why they wouldn't necessarily tell everyone and why it's just with key people, but that can cause issues after the death. They then seek permission from healthcare workers for the assisted death, and that was about trying to locate a doctor who could help. So which often, as I said, would end up with the Right to Die Association. The Right to Die associations would work with them. They would travel to their area. Most deaths are at home, and they would organise the deaths with them. And then in the aftermath, there was the family bereavement. And in Switzerland, there's very little bereavement services. It would be more pathologised and maybe referred to a psychiatrist. And we found that even though, I guess Switzerland's well known for assisted dying, it was still quite secretive. Some family members were never told, just grandma died, not that grandma died of an assisted death. So there was a lot of secrecy still after the death. and which puts a burden potentially on the family who were aware. But overall, even if they didn't really agree necessarily this was the right path, they really took great joy, really, and they respected the wishes of the person they were supporting. So just a couple of quotes. He left good, he left how he wanted, surrounded as he wanted. So the bereavement has gone fine. And actually, when we reviewed the literature on bereavement, it did seem to go quite well. People seemed very prepared for the death, and I guess they knew when it was going to happen, and this idea of respecting. However, as this participant said, the violence is there too, a different violence comparing to a natural death or a classic suicide. It's there, but it's spread over the people. So there's still something there, and there can still be the aftermath that has the violence within it. This came out of our research that Jan Fish did, where she was exploring the bereavement experience of UK citizens who'd gone overseas for an assisted death, predominantly Switzerland, leading up to the death, where they're enabling the person, helping the person to get the assisted death. They had, obviously, it was the UK anxiety of illegality, but there was also this kind of suspension of their feelings. So this is very focused on the person accessing the assisted death. So they couldn't kind of go to their own feelings at the time. They were also gatekeeping who knew about this. They were very much acting on behalf of the person seeking the death. And there was also this stigma around suicide. So this could lead to a feeling of isolation leading up to the death, whereas perhaps normally leading up to a death, you would be reaching out to multiple people for help. But after the death, a lot of people talked about campaigning, wanting a change in the law, and this helped them within their bereavement. And this is where the anxiety started to lessen. They would open up and they would challenge the stigma of suicide. And this is when they started to join with others. So it was, you know, different on each side of the experience. Just thinking about this never normal, which came up with the healthcare professionals. This was from a patient, a bereaved family relative, who said everything about it was just heightened. Every moment becomes really precious. It's impossible to believe that this living person in front of me is going to be dead in a few hours, just impossible. That evening was very hard because we had a meal together, her last dinner. Neither of us was very hungry, but we had a glass of wine. She joked it was her last supper. And I think there's something that we don't know quite yet about what are the rituals around an assisted death, and they're still being developed. But during the dying, this person described what they saw. So the worst bit for me was she started being sick because it tastes very, very bitter. But then she just said, I feel woozy. And we got her on her bed. We tried to lie her down, but they said, keep her upright for a bit so the drugs can go through her body. And she lay down, went into a deep sleep. And after 20 minutes, the physician says she's gone. It all happened very quickly. She just left. It was peaceful, but it stayed with me. I mean, I guess any death would stay with you, but often these deaths, particularly the British families, they were on their own. They rarely went with many people. Afterwards, this is a quote from someone. So that was tough because I had to deal with the emotional responses from all these people I didn't really know very well. People had known my mother had been very ill, and for some people wrote to say they felt her choice was quite understandable. Others seemed very shocked and disappointed that they'd not known about her plan before she died. And it's sometimes you can get real family disharmony about this, and because, you know, why didn't my dad tell me? Why did people go ahead without including me in it? So we have a number of concerns which Suzanne will address, you know, but key is how do you find willing clinicians? There's fear of involvement might lead to attack, fear that if supportive will go against their career, and obviously this issue around companies not wanting to be associated and pharmacists with dispensing. And this can leave families a little bit isolated on their own. There are navigators in countries like Australia who are trying to help with this, and I think that would be key if the law was to change here. But they really do need support through the whole process and need identifying that they are who needs the support. But as as I said before, there's been minimal support after in some of the countries, and bereavement services would need to be appreciative of the changes. And then, of course, there's the huge challenges of introducing this to the NHS, which Suzanne will cover. We do have some resources, including a little short film which tries to cover all of this, and some more accessible parts that we've written up in the conversation. But I'll hand over to Suzanne now.
Thank you, Nancy. I'm just sharing my screen. Hopefully that will work shortly. Okay, could people just confirm if they can see that, please?
Yes, we can see it, Suzanne.
Lovely, thank you.
It's not on slideshow yet, though. Oh, now it is. Great.
Perfect. That's great. Thank you. So yes, for the second part of the presentation, as Nancy said, I have two areas of focus. So I'm going to start off by taking you through our proposal for a model of assisted dying, which we feel should be outside of the healthcare service and the kind of key elements of that. And then for the second half of my presentation, I'll look at the bill currently before Parliament, the Terminally Ill Adults End of Life Bill, and just give some of our reflections on what we see as the kind of key elements of that bill. So drawing on the findings from Nancy's research that she's discussed and my previous work on a demedicalised model of assisted dying, in our view, a model outside of healthcare, which is something that could be more preferable for countries like the UK that's currently considering a change in the law to allow some form of assisted dying. So we have a figure here to demonstrate what this might look like, and I'm going to highlight some of those key points. The kind of system that Nancy and I are proposing would remove the need to embed assisted dying in the healthcare service. So there'd be no loss of trust or confidence in healthcare staff. And of course, that's a fear reflected in memories of the Liverpool Care Pathway debacle in the UK. Crucially, the process of review would be both prospective and retrospective. Now, in most countries which permit some form of assisted dying, reviews only happen after the assisted death. This means there's no oversight of the whole process, with estimates from Riley, for instance, in a 2023 paper in the Journal of Medical Ethics, that up to 50% of assisted dying cases in Belgium are never reported. Greater protection for people who may be potentially vulnerable and could be coerced would be offered through a system of prospective review and approval. To avoid people being lost when navigating the system, we'd need clear public messaging about how to access an assisted death. The review and approval body we propose draws on assisted dying models such as those in Austria and also Victoria, Australia. Although we should note that in Victoria, Australia, the prospective review role before the assisted dying takes place is carried out by a representative from the Department of Health in Victoria rather than their voluntary assisted dying review board. But we propose an assisted dying review panel that would require reports from specialists, including, importantly, palliative care. This would remove the decisions from doctors alone, because on those panels could be, besides a healthcare professional, a psychiatrist, a palliative care specialist, a lawyer, and an ethicist, for example. These panels could be accountable and report to the High Court, or they could be regulated by a newly constituted assisted dying tribunal. One important aspect of the model that we're proposing would, of course, be assessment of mental capacity and assurance that all options, including palliative care, have been explored. Part of the assessment would be the submission of a palliative care doctor's or nurse's consultation report to demonstrate this. Of course, family members and friends must also not be forgotten, as Nancy's research shows. Methods to support families both during and after the assisted death through bereavement support are vital. How this model that we're proposing of assisted dying should be funded, and indeed any model of assisted dying, how it should be funded, is of course a significant question. We're currently working on a paper that compares a model that's fully funded by the state with a partially or fully private model, with some or no funding by the state. If assisted dying were to be fully state funded, we do think there's a real risk that that would communicate the wrong symbolic message, particularly when the majority of palliative care in the UK continues to be provided by charities. Looking to international examples, the assisted dying system in various Australian states, for instance, is a partially private model. We can see from this map on the right here from end-of-life directions for aged care that assisted dying is now lawful in all Australian states. It does remain unlawful still in the Northern Territory, that grey area that you can see, and also at the moment in the Australian Capital Territory, or that's set to change in November of this year. State governments funded the development of the required systems for assisted dying, the employment of care navigators and pharmacists, the education of clinicians and the establishment of review boards following the legalisation of assisted dying. But assisted dying and its associated costs aren't subsidised under Medicare. Medicare is Australia's state-funded health insurance scheme, which means that doctors who provide assisted dying have to privately bill patients. According to Hunt, in his article published recently, some doctors are reluctant to charge fees for assisted dying services, and so their work can be unremunerated and altruistic. If we take Queensland, for example, patients don't have to pay for the assisted dying substance or supply, but there are costs and fees associated, of course, with consultations with the doctor. They're not eligible Medicare costs. This partially private model then that exists in Australia might pose financial challenges for patients or essentially be partially funded in some cases through doctors' altruism. A fully private model operates in Switzerland, where Right to Die organisations such as Dignitas and the individuals who are seeking the assisted death cover costs. If we were to have a fully private model, that could include funding from charities, Right to Die organisations too, if that were needed, to better enable equality of access. In contrast to our proposed model, the Terminally Adults End of Life Bill, which is currently before our Parliament, reflects a model of assisted dying that exists within the healthcare system, funded by the state. On the face of it, that might promote equality of access, but I've already noted our concern about the wrong symbolic message that could send. There's also a serious challenge of additional costs to an already struggling NHS and a resource issue for doctors. So we've got this difficulty of finding the right balance in terms of funding between equality of access for those seeking an assisted death and concerns about finding the funds to cover an additional service in an NHS that's already struggling with inadequate resources. Some of the key aspects of the proposed model under the bill are that only terminally adults with capacity for whom death is expected to occur within 6 months would be eligible. And if you look at the bill, it does contain detailed eligibility requirements. It requires assessments from 2 doctors and prospective approval from the High Court. But on that prospective approval from the High Court, key figures like, for instance, the James Mumby, who is our former president of the Family Division of the High Court, have expressed concerns about the appropriateness of this approval role for the judge and the costs and delay that would be involved given the existing demands and strains on our justice system. In oral evidence, some of the experts before the public committee that's currently scrutinising the bill and considering amendments argued for an alternative panel system. And this is also more recently within one of the amendments that's been proposed for the bill. The bill places responsibility for initial discussions about assisted dying on medical practitioners, albeit that there wouldn't be a duty for a medical practitioner to raise assisted dying with a patient. It's worth noting here that the quote that Nancy gave before from the EAPC's white paper on euthanasia and physician-assisted suicide from 2016, that it's the responsibility of palliative care professionals to hear and explore the implicit or explicit requests for euthanasia and address the suffering underlying these requests. Now, under the bill, if a medical practitioner is unwilling or unable to conduct the primary discussion with the patient, then if the patient requests them to do so, they should identify another registered medical practitioner who they believe would be willing to have that conversation with the patient. But that identification may not be an easy task, especially in light of Nancy's research findings. So patients could seek information about assisted dying and receive misinformation from less reputable sources. In contrast, under our proposed model and in line with the BMA's preference in a summary document that was available online until last month, There'd be an official body. We call this official body in our proposal an assisted dying panel. And in the words of the BMA here, that official body could provide factual information to patients about the full range of options available to them so they could make informed decisions. This would ensure doctors who did not wish or didn't feel confident to provide information to patients about assisted dying had somewhere they could direct patients to, importantly, in the knowledge that they would receive accurate and objective information. A representative for the BMA who gave oral evidence to the public committee last week did continue to express support for such an official body. And indeed, it has also been proposed in an amendment to the bill. It's called in the amendment as Assisted Dying Agency. Of course, this assisted dying agency or panel would obviously need promoting to the public so they were fully aware of the process involved and where they could go to get important information. Something else under the bill that we consider is really significant is that registered medical practitioners will conduct the necessary assessments and then provide assistance. But as Nancy's research has shown, few doctors are willing to participate. So integrating assisted dying into the NHS would pose significant challenges, including finding enough doctors to assist. It would also be challenging to find enough time for doctors to assess, to prescribe, to appear in court, as is also required under the bill, and also to deliver the medications. Even more time will be required to remain with patients until they die. That's also something that the bill requires. If we look to Oregon for an example here, in the 2021 to 2023 data, over 30% of assisted dying cases took over an hour to die and 7% exceeded 6 hours. So in our view, there should be a list of volunteer health professionals trained in palliative care options and assisted dying. These volunteers could be identified by the assisted dying panel when an application for an assisted death is submitted. At this moment in time, as the bill continues through its parliamentary stages, we still don't know whether it will be passed, and if so, with what amendments. We've submitted written evidence highlighting the issues that we've discussed here today, and also other concerns that we have to the public committee that's currently scrutinising the bill. Nancy also gave oral evidence to the committee last week, along with other palliative care experts. So we await with interest the next version of the bill when it comes back to the House of Commons for its report stage and third reading in April. But that's it from me. And as Nancy has done, I've also provided a list of resources here, and I believe the slides will be shared afterwards with everybody. And thank you very much for listening.
Thank you very much, Suzanne, and thank you, Nancy. That was such an interesting presentation. So I'm going to have a look in the Q&A for questions. So there's more of a comment from Celia Manson. She said a big theme of secrecy running through the accounts of the international experience, and that's something that I've noticed as well and was going to ask you about. I wonder whether you want to say anything more about that. And I was particularly thinking about the long-term secrecy of families in that sort of longer-term bereavement period, and whether things remain secret and how they feel about that.
Yeah, I think the biggest impact is probably the secrecy around the death at the time of the death and then finding out afterwards, and people working that through over time. But we interviewed some people up to 2 years later, and a few people still commented on it was difficult within families. And I think that period of time when you're leading up to the death, just speaking to a couple of people who've gone through it, even in countries like the Netherlands, where this is much more open, it's the disagreements leading up to it between family members, which is why I think the secrecy continues. And there's also this big secrecy of healthcare staff. Lots of healthcare workers will say, well, I do it, but I don't tell anyone, or I'll do an assessment, I won't do the other bit. And they don't want to be known that they're even involved in it. I know even doing research in assisted dying, it's potentially problematic about how you'll be perceived. So, and I remember being very nervous about supervising the first student because it's such a taboo area. And I think definitely people raise concerns about careers, the rest of it. But yeah, secrecy is quite a big issue. I thought we do a film and we've shown it at various palliative care conferences. And when we showed it in the Netherlands, I thought they would say, oh no, the secrecy isn't an issue here. But actually people came up to us and said it still was a big problem.
And of course, here at the moment, families who do help their loved ones go abroad to Switzerland to have an assisted death, the secrecy is there because of that real fear of prosecution. And whilst we know that people aren't generally prosecuted for doing that, they are still committing an unlawful act. So there's a stigma that is attached to all that, which inevitably promotes secrecy.
Thank you, Suzanne. Irene, you've got your hand up.
So first of all, to say, please, I encourage people to put questions in the chat, and Morag will read them out. It'd be great to, we've allowed some time for discussion, so do. While people are getting their ideas together, I had two reflections, but first of all, I wanted to say thank you very much for a very thought-provoking set of presentations. And I had two questions, really. One, really focused towards you, Nancy, about the terminology that you raised, and in a way that assisted suicide is a term that's perhaps more frequently used than assisted dying, and is a little bit more, in truth, what it is, because it is somebody choosing to die who wishes to take their own life and is helped to do so. So I wonder if you could reflect on why we've gone that way with the language, and whether that actually is a hindrance for us. And then the other question I had, which perhaps Suzanne, but maybe you both would reflect on, is about the capacity. So we know, and Suzanne, you mentioned it, about the shortage of clinical and social care, actually, that we have at the moment in this country. And in particular, palliative care, as you flagged, is in short supply, but also psychiatry is in short supply. And I, even with your model, I wondered whether we had, and whether you'd estimated how much professional capacity and time might be needed for the number of people who would want to have this set up. And that would include people who did choose to go through with it and didn't choose to go through with it, if you know what I mean. Because we know from the Oregon experience that quite a lot of people sort of set it up and then don't go through with it. But presumably the safeguards still have to be explored in the same way. So has anybody actually thought of the resourcing and implications of that for the healthcare system? So thank you.
So if I start with the terminology, I mean, I think when I first started doing research in there, it was exactly that: assisted suicide and euthanasia. That was the two. And it was really kind of simple in a way. I think it's where it's changed is more about the North America experience and now the Australian experience. And it really is an incredibly loaded term. But the Health and Social Care Committee, if I'm correct, used the term assisted suicide. So I think, you know, I think it does help with the clarity, and certainly no one in any of our interviews outside of the US commented on the phrase suicide. As I said, people were just very grateful that they'd finally accessed it. So what it was called was less of an issue. I think some of the healthcare workers did talk a lot more in the US about, this is why this question came up, is it a suicide? Is it a natural death? And what is it? But it was very a North American thing, to, I would say. Suzanne, I don't know if you want to comment on the capacity.
Yes, I can do. I haven't actually got figures, and I was just trying to dig out some figures, which I came across in one of the discussions when the bill was just about to be released before Parliament. But what I would say on capacity, I mean, I agree with you, Irene. I think there is a real issue about resources, full stop, but particularly about who will do this. In the oral evidence, the doctors who gave evidence did say that they are used to making capacity assessments, and they would be confident that they could do this. I think a particular concern for me would be the level of scrutiny that would be required under this bill, and in the committee, when people were giving evidence before the committee, capacity came back as a reoccurring issue, and they had a barrister, Alex Rutkeen, who spoke about that. But under the Mental Capacity Act, we have this presumption of capacity. It's a rebuttable presumption, but it is there. And to my mind, the kind of scrutiny that would need to be involved in capacity under this bill, if assisted dying were to be permitted, it really challenges that presumption of capacity. And to me, it's almost an exception to that, what we would normally take as you have capacity unless you fail to meet the requirements of the Mental Capacity Act. So I do think that needs further serious consideration as well.
Thank you, Suzanne. I also had just a I also was thinking of capacity in two ways. The mental capacity that somebody has to make a decision, but also, do we have enough staff in palliative care? And how many staff would it take, given that we know that it's a shortage? Psychiatry equally, particularly psychiatry for older people, is in a shortage field. So do we have enough staff, and how much staff would it take away from other forms of care potentially? And it's just about knowing what those figures might be. But thank you for the capacity answer as well.
And the other thing I'd add on that is it's not just about capacity, it's about the bill's really clear on checking there's no coercion, checking there's no pressure. So there's that element as well. How much time and resource is going to be involved in doing that? And indeed, are healthcare professionals, the palliative care professionals, going to be able to identify coercion, as well?
Yeah. Great, thanks, Suzanne. So there's a question in the Q&A, an important one about, in your proposed model, will the AD review panel consist of members who are diverse in terms of ethnicity? And I guess we should add to that in terms of other aspects of diversity as well. So any thoughts on that?
I mean, I think in an ideal world, yes. I think it probably comes back to Irene's point about capacity and palliative care in particular not being the most diverse group of practitioners, which is also an issue. But I think what you're raising is a really important element about ethnicity. And I think a big concern of the panel at the moment about inequality and things like that. Overall, what most of the data says is this tends to be white, educated, middle class individuals, not exclusively, but there's a potential that people from groups not like that are more protected from this because it's more of a taboo in their groups and their societies. There's almost a question about how do you make sure those people are informed so they have equal access. It's almost the other way. And I can remember speaking to someone 2 weeks ago who's a palliative care doctor in Canada who does research in people from mainly from South Asian background about access to palliative care and their understanding of it. He said he still hasn't seen anybody from that community go forward for an assisted death, but they have seen people from, say, the Chinese community come forward, maybe second, third line sort of immigrants. So I think it's going to change over time, but it's definitely something we need to be really aware of.
Okay, so there's another really important question. Do you have any data on outcomes of children bereaved by euthanasia compared to other bereaved children? And I would just add to that, again, thinking about the sort of the longer term bereavement, perhaps in particular.
So we didn't have any access to children in any of our interview studies. And I think, and my guess is, I don't think anybody's really looked into that too much, but I would say how children are involved in this, and this goes back to we haven't quite worked out how we do the rituals. I can remember one of the interviews when there was a mother and she had a 12-year-old child and she died with the child in her arms as the doctor was injecting her. And I can remember reading that, finding that really quite difficult. I mean, I suppose the child would be there anyway if the mother was dying, but it's just there's something very different and non-normal about this and the experiences of those children. And it must feel different. And I think that is an area for research, definitely.
Yeah, thanks, Nancy. So another question is, what are your thoughts about the fact there's no mention of current suffering in the end of life bill, that the decision is entirely based on fear of what might happen when most deaths are in fact peaceful?
I think one point I would make about the different jurisdictions in which assisted dying is lawful is that we see some jurisdictions focusing on terminal illness, so Oregon would be a good example of that. Other jurisdictions like the Netherlands focusing on the suffering element without the requirement of a terminal illness. But I think the danger and one of the main reasons I suspect why the terminally ill adults bill is framed the way that it is that if there is to be any slippage in terms of a slippery slope and an extension of the criteria for eligibility, it's more likely on the evidence that we have from other countries to happen if we have a criteria which focuses on suffering and an assessment of the level of suffering than criteria that focuses on the the illness and the requirement that the illness is terminal, and that's when we see that there isn't really any slippage. But in jurisdictions like Canada, for instance, where we do have that broader eligibility criteria which focuses on suffering, that's where we do see problems in terms of an extension.
And I think that's why we're suggesting that everyone should have some sort of palliative care consultation, whether that's with a palliative care clinical nurse specialist, whoever, but you need to understand what you're thinking about, because you'll be basing it off previous experience, or else, I think Anna-Marie says, potentially fear. And we've got to talk this through with people so they can make an informed choice. Now, I think, as I said, often these are people who will talk more about being in control, and that's why they want it. But we shouldn't be having, I think probably the general public's view is very, very fearful of what dying is about. And that's why it's so important that people are informed.
So a couple of linked questions from Catherine Sleeman. Thank you for an incredibly helpful talk. I can see there's a lot to be said for taking this out of the NHS. Question 1, do we know what the public think about this? I would imagine that the public might want this to be part of the NHS, as it would feel safer and more familiar. And then secondly, how likely do you think it is that the committee will amend the bill in this way?
I mean, I was just going to say, Suzanne, I think we can't probably answer that, but definitely the feeling we get is that the public assume it's going to be, I mean, if you listen to Terry Pratchett, it's my doctor, he's sitting with me at the end and I'm drinking a glass of whiskey. I mean, how many GPs are going to have the time and the capacity to do that? It's highly unlikely. So I think people need to be made really aware that the likelihood is it isn't going to be a doctor or a nurse, currently it's just a doctor. So I think when people are saying they want a change in the law, they need to appreciate, even if this is in the NHS, it's you do very well if it's someone you know. But Suzanne, I wondered if you had anything from the citizens jury on this.
Yes. So I was thinking, so the citizens jury, both the Jersey citizens jury and the Nuffield one, the main questions of the jury were the kind of in principle questions about whether there should be a change in the law to permit some form of assisted dying, and there wasn't as much, if any, real time spent on the kind of how that would be done and the different models that we've been talking about today. What I will say is that, and particularly remembering from the Nuffield Council, Council's citizens jury, is that the citizens who were members of the jury were thought that equality of access was very important, and if the law was to be changed, and in fact the majority of both of the citizens juries when they made their votes, cast their votes, were in favour of a change in the law on assisted dying after they'd heard all the evidence, all the kind of complexities of the debate. But yes, one thing that I do remember was that the Nuffield Council's jury, they were very keen on making sure that that was available to everybody. So I think implicitly in that, it might be this perception that would happen if it was through the NHS.
Okay, thank you. So another question, thank you. It's been a very interesting, the comment from the Netherlands where they said that 6 assisted deaths per 6 months would be a lot. How many assisted deaths do you think clinicians would be expected to perform if it goes ahead in the UK? And therefore, how many assisted deaths would actually happen?
I mean, I think there's some estimates from Canada. I think they said it's 89 doctors have performed 5,500 deaths. So this is very much not part of integrated healthcare. In Canada, these are these MAID teams going around doing it. So just say the rest of it more. I can't quite see that one on the list.
Apologies. So how many assisted deaths do you think clinicians would be expected to perform if it goes ahead in the UK, and how many assisted deaths would actually happen?
I mean, I think what we've shown is the first year in most countries it's very low and then picks up. And I don't think there would be any expectation on anyone on how many, it'd be how many you feel you can do or not do at all. So I think most people would do none. A minority of people might do a couple, and then the majority would be done by doctors who would probably self-identify as willing to act in this way. That would be my guess. Even if that's in the NHS, somehow they're going to have to find these people who are willing to take on this act.
I have now found some figures as well, the ones I was looking for. So this is Oregon, and we can extrapolate perhaps from that what we will, given that it is a similar model to the bill that we had before Parliament. But 0.8 of the Oregon population accessed an assisted death in 2023, and the figures I have, it would, if the same was to happen here, we'd be looking at around about 4,500 deaths per year, which perhaps goes back to Irene's question as well about how many of these assessments would be needed.
Okay, thank you. Is there anything in the international research about patients who've requested an assisted death being concerned about being a burden on their family or the healthcare service? I know that was a very big concern about this here in the UK when MPs were initially voting on the bill.
I think that mainly comes to mind to me, and it goes back to this characterization of someone being in control. Linda Ganzini did a lot of the research in Oregon and early on, and she's a psychiatrist, and she talked about, I don't know if she ever wrote about it, I heard her talk about it, Oregon man who's the hunting, shooting, fishing guy. No one is going to take them to the toilet, help them get dressed, things like that. And so for him, they wouldn't necessarily say the word burden. I think the person caring for them would say, but you're not a burden. So it depends on, I think the phraseology is tricky both ways. And but I think there is obviously always going to be a fear of people doing this because they don't want to be a burden. But I think it's almost more than that as well. And I think this has come out in the bill about people making choices based upon the current healthcare or social care they can access. So if this is as good as it gets, do I want this? But then on the other side, do we then condemn them to say they have to receive this? So I think all these things are really complicated, and even a word like burden is quite tricky.
Yeah, I agree. And knowing as well, you know, the evidence I've seen suggests that it can sometimes be part of the reasoning. Extrapolating how much of the reasoning it actually is would obviously be a really, really difficult task. And I guess we've got to remember that the person who's making this decision to have an assisted death is doing that in their particular circumstances, in their family circumstances, etc., etc. I think inevitably feeling like you are a burden is something that for some people will be there.
Yeah. So a question from Sharon Hudson. I'd be interested to understand the equity of access and impact of poverty on those choosing and those able.
I mean, I think this has come out mainly in Canada. I think where there has been real issues about people choosing this. I suppose, like I said, if this is as good as it gets and I can't get good enough care, I can't get good enough housing, then you're going to have an issue there. I think what we're not seeing is that happening in places like the Netherlands, but then they have a much better, probably social support system, better access to healthcare. So, you know, if your choice is, do I want to keep being readmitted to a corridor ward in A&E, it all becomes very difficult. Where if you've got access to better care services that can maintain you at home, you may not make that decision.
Yeah, I agree.
And then we've probably got time for just one more, possibly two more questions. So thanks, really interesting talks. Could you say again the average length of time for people to die after taking the lethal drugs, and do you have a reference for this?
So the reference for this is there. So if you go to the resources, the final slide when they're distributed on my part of the talk, there's a reference to the Oregon data, and that information is there. And so the particular statistics that I took out from that and gave in the presentation were that in 30% of cases between 2021 to 2023, it took over an hour, and in 7% it took more than 6 hours.
But I think the other thing is to say the bill at the moment is open. So it is open enough that it could be an IV that the patient opens, in which case the death would be much quicker. And again, how aware are the population of that is potentially where the bill could go? And will they be deciding on that when the bill is voted upon? Because it's starting to creep closer to euthanasia if you're going to use an IV drip that a patient opens. They are ultimately doing the final self-administrative act. But I suppose there's a perception of how that feels. But obviously an IV would be much quicker.
So very final question that we'll squeeze in, and this is an issue not so much capacity, which can be assessed, but how fully autonomous the decision is. How can we ensure that the decision is free of coercion, whether real or perceived?
I think that is an enormous question, and I think impossible for us to answer in a minute. What I would say on that is I think it is going to be a very difficult thing to assess. The evidence that is available worldwide doesn't suggest that coercion is an issue, but then I guess the response to that would be, well, it may be then that cases of coercion are going undetected, and that's why it doesn't seem to be an issue. But yes, making that assessment, who has the training? I mean, training will be crucial on this, and I know there are screening tools and assessment tools elsewhere in the US. For instance, California has particular tools that they employ to assess issues to do with coercion and undue influence as well. But I think it is a really difficult one that can't very easily be resolved.
Thank you both so much for an incredibly clear and thoughtful presentation. There's been a number of comments in the chat commending you on the clarity of presentation on what's a very difficult and sensitive topic. So just to point people to the evaluation and feedback for this webinar series, please respond to our Mentimeter, which I think is also in the chat. And if there are particular topics you're keen for us to organise presentations on, please let us know, because it's really important that these webinars meet the needs of our audience. So thank you very much, everybody, and thank you again to Nancy and Suzanne.